fellow by the name of Judy Turner, who some of you probably know. She's extremely talented. And one year she said to me, "You've got to meet Dr. Susie." I said, "Dr. Susie, huh?" And she said, "Yes." And I said, "So who's Dr. Susie?" And she said, "Well, she's in practice on Oahu, and I just spent a month with her, and she's the world's living expert on the McManus table, because Mrs. Dr. McManus taught her how to use it when she was going through Kirksville in the 1930s. And I, of course, when she said, "You've got to meet Dr. Susie," I'm thinking, yeah, I've got to meet a lot of people, because I didn't have any idea who Dr. Susie was. So Dr. Susie, actually, then I wound up meeting her at Kirksville that year at Founders Day, and it turned out that she was indeed the world's living expert on the McManus table, and I was able to glean a great deal of interesting information from her, and went down actually and spent time with her in her office and studied this a little bit with her. Then we had her come over to the college and teach the students. And although McManus tables are hard to get, the people who have them absolutely love them, because there is no other table that will do what a McManus table will do. So I thought to myself, okay, next time Judy says you've got to meet somebody, I'm going to have to pay attention. So about a year later, she said, "You've got to meet Dr. Steve Tipaldos." And I said, tell me about him. Okay, so she said, "Well, he's in private practice. He's down around the Dallas area, but he's come up with a new technique, and it's called trigger band technique. And I was doing it with him, and this really makes sense. And it's something that we ought to get over here to the college, and we ought to get it out to more people." So I tried to contact him when I was setting up this program, because I thought, I know this, she had said, works perfectly well with the extremities, and we were working on extremities techniques. So I thought, okay, I will see if I can get a hold of this doctor. So I called down there and talked to somebody, and guess what? The number was no longer good. So I had to track him all the way to Maine, because he had moved up to Maine, and he's now dividing his time between Texas and Maine, and I think he's got an absolutely brilliant idea that we're all going to be glad we've heard. So let me introduce to you Dr. Stephen Tipaldos.
When I started preparing for this lecture, I wanted to give everybody one thing to hang on to. So when you leave this room, you remember one thing. And that one thing that I thought about that I call a memory hook. And some of you in the front row can see this, but that memory hook is, think trigger bands. How many people out here have heard about trigger bands before, or trigger band technique? So there's quite a few people then. Trigger bands are around us all the time. They're not something that we normally think about, but they're a lot more common than you might have guessed. And trigger band, we just went through these slides. This is a professional ballerina, but she's not that great. But trigger band technique is the way that we correct trigger bands, although there are other osteopathic techniques that may be helpful as well. Trigger band technique is anatomically the most specific way to correct the trigger band. But before we get on to how to do trigger band technique, which is what I'm sure everybody is most interested in, I'd like to talk about the anatomy a little bit and what exactly a trigger band is. As you can see up here, these are two of my patients from the Fort Worth Dallas Ballet. And the woman there, who is sideways, is Maria. She's a star of the Fort Worth Dallas Ballet. And she came to see me one day with low back pain. And as I went through the motion with her, she had beautiful motion. She could do everything. She could take her foot and put it on the ceiling. She could do everything except for one thing. One thing that she couldn't do was this. She couldn't do that with either leg. And I asked her how long it had been like that. And she said, "It's been like that since I was 9 years old." But she didn't have a complaint necessarily of thigh pain, although later she told me it was tight. She was complaining of low back pain. And what she had was trigger bands in her thigh that she had had since a child. And even though she was a professional ballerina, the star of the Fort Worth Dallas Ballet, she couldn't touch her heel to her buttocks. And obviously this decreased her performance, caused her a lot of aggravation, made her more tired than she would have been. So we have an athlete in prime condition who was not as good as she thought. And what she had were trigger bands, and after the treatment, she could do that easily with both legs. It took about 4 or 5 treatments, And she went on to not have any more back pain, and she is still the star of the Fort Worth Dallas Ballet. This is a little picture you can see up in the front. And when we think about fascia, we usually don't think of it as being in fascial bands unless we talk about the iliotibial band. But I'd like you all to start thinking about fascia as running in bands, that it has a starting point and it continues on. If you look at the lateral collateral ligament of the knee, you'll see that the fibers of the lateral collateral ligament of the knee, some of them come actually from the ilium. And so that when you have an injury to that knee, you can be affecting that entire pathway from the ilium all the way down through the interosseous membrane into the ankle. And you can see on this little picture here that there's a parrot there tucking on the pants. And when we get a trigger band in our leg, that causes that fascial band to become shortened. And when it becomes shortened, that causes a tightness. That's a mechanical type of pain. So you can think of trigger bands as being a mechanical type of pain. In this example with the little parrot, I could feel that parrot tugging on my pant leg, but there are no nerves in my pants. But I could feel it all the way up to my belt line, because my pants could function as a mechanical sensory system, the same way the fascia can function as a mechanical sensory system. And when the fascia becomes tightened, it gives us a mechanical sense of pain. And it also gives us a proprioceptive sense of where our body is in space. And so for the ballerina, after the treatments, you can enhance performance on where her body is in space because she had a trigger band that was doing this. And trigger band technique is a manual method for correcting trigger bands. It's done by using force from the physician's thumb along the entire course of the trigger band pathway. You cannot use your finger. And in a minute, I'm going to show you exactly how this is done. As we talk about trigger band technique, we really need to think about trigger bands. And the important thing to remember with trigger bands is we need to watch for the signals. Our patients are out there telling us all the time, I have a trigger band, and we have to know how to listen for it. Anytime there's a pulling or burning type of pain, anytime a patient does this, or they do this, or they do this, or they do this, or they do this, they use a sweeping motion with their fingers. That's their way of subconsciously telling us, I have a trigger band. And we have to be ready to listen to that so that we know when to use trigger band technique. If they take a finger and they point, and they say, I heard right here, that's not a trigger band, that's something else. If they take their hand and they cup it over their shoulder and they say, my shoulder's killing me, that's not a trigger band, that's something else. If they say it hurts deep in the joint, that's not a trigger band, that's something else. And all these something else's have names, but I'm not going to get into it today. But if they make a sweeping motion and they say, I have a pulling pain, I have a burning pain, then they're talking about a trigger band. And that's something that, if you can remember that, you can think trigger band. So if somebody comes into your office and they say, gosh, you know, I reached in the back seat, oh, my shoulder's killing me, and they're doing this. You could think of that as bicipital tendonitis, or you could think about that as a trigger band sore shoulder. If somebody is walking down the stairs and they trip, and their foot does this, and they fall down the stairs, and when they get done, they can't walk, and their lateral ankle is immensely swollen, and they can't put their shoe on, and you get an x-ray, and that x-ray looks normal. You can call that a sprained ankle, or you could think of that as a trigger band sprained ankle, although there are other kinds of sprained ankles. And if they have that pulling pain that comes up the calf this way, and they twist the foot like this, you can think of that as a trigger band, and you can treat it with trigger band technique. If somebody comes in and they say, I've got a pulling pain on the bottom of my foot, and it goes from here to here, you can call that plantar fasciitis, or you can think of it as trigger band plantar fasciitis. And of course, the advantage of thinking of it as a trigger band or considering it to be a trigger band is you can use trigger band technique, or you could use other osteopathic techniques that may also affect trigger bands, although trigger band technique is the most specific. And you have a good fighting chance at helping these people with trigger bands. This is a baseball team that I played on 2 years ago, and this is Marty on first base. And he's on the base there during the middle of the game, and he wants to know, should he steal second base? This is Big John, who's our heavy hitter, and he's at the bat, and he needs to know, should he swing away, or should he take that pitch and let him steal the base? That's my car in the background there. And this is Robert, who is our coach, and he's giving the signal. He's going to tell Big John whether he should hit or he should take the pitch, and he's telling Marty whether he should steal the base or not. Those guys are looking for the signal. But what if Robert gives them the signal and they don't know what the signal is? Then they're not going to know what to do. It's the same way with trigger bands. Our patients are giving us the signals. These are the signals. My shoulder's killing me. I got a pain that goes from here to here. I've got a burning, pulling type of pain. If we're going to do well in this game, these players have to know what the signals are, and then they have to act on it. But if they don't know the signals, if we don't see the signal, then we're not going to think trigger band, and we're not going to use trigger band technique, and we're not going to do the other things that might be helpful for that patient. We're going to miss the signal, and the patient's not going to do as well as they might have. By the way, in this game in particular here, it was memorable for me because right after we took these pictures, I ended up breaking my ankle. I want to talk about pulled muscles just for a minute. Pulled muscles are considered to be within the fascial distortion model, which is the model that trigger bands are one part of. In the fascial distortion model, pulled muscles are considered to be trigger bands. And if you think of a pulled muscle, it comes and goes. Somebody will tell you, gee, I was out running and I got a pulled muscle, and it hurt like heck. And then I rested it for a while, and I felt a little better. I did a little myofascial release on it. It felt a little bit better. And after a while, I was okay. I went out and I played, I ran, and that muscle wasn't pulled anymore. And then about a month later, they come hobbling back to you. And they say, I pulled my muscle again. They've re-injured that. They have the exact same injury. And they may do this repetitively. You may have somebody that you've seen that's pulled the same groin muscle 5 or 10 times. And they keep saying, why does this keep coming back? What's wrong with me? Am I injury prone? In the fascial distortion model, they're not injury prone. They have a trigger band that has been not treated. And what happens with it is, I don't know if you can see this, but at the very top, you've got a guy sitting with the seatbelt on. There we go. And you can see that there's a distorted fascial band right next to the muscle. And that person, when they've got a distorted fascial band next to a muscle, they're going to say, yeah, it feels a little tight, but I'm okay. But they might have that feeling that, gee, if I turn this wrong, if I run a little too hard, I'm going to pull that muscle again. And then when they do one of these things, and they run a little too hard, then that twist becomes pulled into the muscle. And you can see the guy in the middle there, he has a twist in his seatbelt. And you can think of trigger bands as being twisted fascial bands. They're twisted fascial fibers. And as those fibers run through the muscle, they can become stuck. And when they become stuck in the muscle, in this fascial distortion model, we call that a pulled muscle. And then if you were to take him and rest him a little bit, that muscle may atrophy just a little bit, and that twist will pull through. Or you may exercise it, or send him to physical therapy, and that may pull that twist through. And then he feels better, but it still feels a little bit tight. And then he goes out and he runs again, and it gets pulled back in again. And he says, I pulled my groin again. Well, he didn't really pull his groin, he just pulled that trigger band back into the muscle. So in trigger band technique, we want to do more than pull that twisted fiber out of the muscle. We want to untwist it along its entire pathway. And when we do that, this trigger band cannot come back again because it no longer exists. And so the goal of trigger band technique in pulled muscles is to not only correct that pulled muscle so that instantaneously they can run up and down the sidewalk, but also so that this injury does not come back again. This injury will not reoccur if it's properly corrected. And again, this is one way of looking at it as a twisted fascial band. We're just going to take our thumb and we're going to untwist that. We're going to push it through the muscle. We push it through the muscle to the other side, and then we continue on and we're going to untwist it. On this diagram here, you can see that this is a knee ligament. And this picture was drawn from an electron microgram of an actual knee ligament. And you can see on the top that in the resting state, that the ligament itself has fibers that are in a wavy configuration. Can everybody see that those are wavy? up on the top left, on your top left. Those are in the wavy configuration, and holding them together are little cross links, which are little fascial fibers to keep them bundled together. And as you straighten out that ligament, it's going to go into the straightened configuration, which is a picture just next to it. And so as we put a ligament through its motion, it's going to go from wavy to straight. But if you put a little torque into there and you do it just wrong, you can cause that ligament, those fibers, those little crosslinks that hold it together, to tear. And when those crosslinks tear, that decreases the ability of that to bundle together. And some of the fibers become stuck in the wavy configuration. So you can see there on your bottom left that the crosslink is broken and that some of those fibers are stuck in the wavy configuration. So that when that person tries to straighten that knee out again, that segment that is stuck in the wavy configuration stays wavy. It doesn't go straight. And when it stays wavy, that means that that ligament's going to be too tight because it can't straighten out. So some of the fibers go straight and some stay wavy. So they're too tight. That also decreases strength of that ligament. The ligament can't carry the kind of weight that it could just a few moments before. It's impossible because only some of the fibers are working. Some are working properly and some aren't. The purpose of trigger band technique is to correct that anatomically. And that's done by unsticking those stuck fibers in the wavy configuration and making them straight and realigning those crosslinks. And once you do that, this ligament will heal almost instantaneously. And that knee will have normal strength after that. This is a picture taken from a great article from Gerlach and Lears, which I have at the bottom of your handout on the first page. It has where you can find that article. For those that are interested, this is really a great article. It's a little hard to read, but the pictures are just absolutely outstanding. They show fascia in a way I think that other people really aren't that familiar with seeing it, that it runs in fascial fibers like this. This is only a few of the pictures taken from that. And again, it talks about how all these different fibers are interconnected. They can be thought of as one and the same. So again, if you look at the lateral collateral ligament of the knee, some of those fibers come all the way from the hip and down to the ankle. So from an orthopedic point of view, when we tear those fibers and we go in there and surgically reattach them, we're not taking into account the entire fascial band pathway which those fibers came from. And so many times you'll see a progression with the trigger band type of injury that they may tell you that first it hurt in the knee and now it pulls all the way up to the hip or it pulls all the way down to the ankle. And this is why, because it's a mechanical link between these. It's a mechanical force. It's all one structure. Not referred pain. In this model, there is no such thing as referred pain. Referred pain in this model, it's a mechanical type of pain, a pulling type of pain that's anatomical. It is not neurological, and it is not referred. Referred does not exist in this model. This is another way to look at a trigger band, that you have fascial fibers that are lined up in parallel form, and that there's a tear between some of the fibers. And whenever those fibers tear apart from each other, or twist, or any kind of distortion of that fascial band, that by definition is a trigger band. If you look there, also there's a broken crosslink. The crosslinks, again, hold the fascial band together. When they become broken, then the band can tear apart. And you can see at the bottom is something called a cross band. The cross band is very important clinically because it tells us where to start with trigger band technique. That tear in that band can continue to tear throughout its entire fascial pathway, but it will stop when it hits another band that is in a different direction to it. So we know when somebody has a shoulder injury, if they come and they complain here, they say, man, it hurts right along the front of my shoulder. That fascial band doesn't tear all the way down to the fingers. It's going to tear right down to here because there's a cross band that keeps it from tearing indefinitely. And so we know where to start on making that treatment. And that's going to be anatomically where that cross band is. Ooh. Can't really see this picture too well, but this picture is in your handout. Another way of thinking about trigger bands, and this is, I think, the ways I've tried to explain it, I think this has hit home with most people. You can think of a trigger band as being a Ziploc plastic bag, but the fascial fibers are similar to the top of a Ziploc bag in that they run parallel. And when you put your hand on a fascial band, and after you get used to feeling for them, you may get an appreciation the fascial fibers themselves are banded and that they feel very much like the top of a Ziploc fascial band, a Ziploc bag. And just like with the Ziploc, the fascial bands are held together. But as you yank on a Ziploc bag, you can just pull it apart. That's how a trigger band is formed. The fascial fibers become yanked apart. And when that happens, they twist. So you can see there in the upper right that there's a twist in those fibers. And that's why trigger bands are twisted. As the fibers separate, they twist. One thing you probably can't really appreciate, if you look on the picture on the left, and you look at the left side of that bag, and you look on the right side of the bag, they're a certain distance. And I don't know what that bag is. It may be 5 or 6 inches. Let's say it's 6 inches. If you look on the one on the right, it's no longer going to be 6 inches across. It may be 5.5 inches, because as you pull the bag apart, the two ends become pulled closer together. And that's the same way with the trigger band, is that when the fibers separate, then they pull the ends closer together, and that's why you get a pulling type of pain. And that's why the trigger band causes it to be shortened. And you can see down on the bottom left side, on the top right side, that the fibers are actually farther apart than they are on the bottom left. And so with trigger bands, they can continue to tear, and they'll tear all the way until the band, its entire pathway is affected. So if the entire pathway is affected, it's just like unzipping that Ziploc bag. The entire bag becomes unzipped. It can't go any further. It's the same way with the trigger band. It'll go along its pathway and it'll stop. And of course, trigger band technique then is we want to realign those fibers. We're going to use our thumb and we're going to force that back together. In the fascial distortion model, acute and chronic mean different things than they do in the orthopedic model. The trigger bands that you've seen pictures of so far are all acute trigger bands. In a minute, I want to show you a couple chronic trigger bands. But in the orthopedic model, we usually think of chronic as being a temporal definition. Somebody will say, gee, my shoulder's been hurting me for 6 years. And most physicians will say, well, that's a chronic sore shoulder. That's a chronic shoulder sprain. That's a chronic type of problem. Sometimes people will come in and say, my shoulder's been hurting for 1 year. And the orthopedist will say, well, that's a chronic injury. And some people will say, my shoulder's been hurting for 6 months. And they'll say, that's a chronic injury. But if somebody comes in and says, my shoulder's been hurting for 6 weeks, people usually don't call that chronic. And if it's 6 days, they say that's acute. But anatomically, that doesn't really mean anything. In the fascial distortion model, we look at acute and chronic as being anatomical definitions. On the left is a picture of an acute trigger band on your left. And you can see that the crosslinks are broken, that there's a tear, and there's a twist. The three usual components of a trigger band. Unless the whole band is affected, this is usually the way we think of a trigger band, is that the fibers have become separated, the crosslinks are broken, and that there's a twist. But those crosslinks, an acute trigger band, to heal, it needs to reattach those crosslinks and pull that band back together. And in an acute trigger band, it has 4 possible futures. One of those futures is it can heal on its own. This is in your handout. It can heal on its own slowly. And this is the way most trigger bands heal, is that you become injured and you say, wow, my shoulder really hurt. But you know, it took a couple weeks, but it's feeling a heck of a lot better. I'm fine now. And what happened in that injury was this injury did heal. But those little broken crosslinks reached out and grew, and they grabbed onto the other crosslinks, and they pulled that band back together, and it healed, and now they're strong, and everything is fine. Trigger bands have another future, another possible future, and that's with trigger band technique. That instead of waiting weeks for this to happen, you can do this in the matter of a few minutes or even seconds. You can just push that back together, realign everything, and just like the Ziploc bag, seal it right back, and instantaneously you've corrected that trigger band. Trigger bands have another possible future, and that future is that this doesn't heal at all, that those crosslinks don't reattach, that they just stay in the state that they're in. And these people are usually what we think of as being very athletic, that they continue to exercise, to run, to do the things that they want to do, and that crosslink never reattaches. And in that case, you might see in your office somebody that has had an injury for 20 years. That's an acute injury. That is not a chronic injury. That's an acute injury. The time does not matter. Now, trigger bands have a fourth possible future, and this is the one that we want to avoid. And this is a future of a chronic problem. And you can see in the picture on your right that that crosslink has reached out, and it has reattached, but to the wrong fiber. And when it does that, that crosslink, that mishealed crosslink, is called an adhesion. So in some of the other lectures, you've heard about people talking about adhesions. In this model, this is what an adhesion is. And the moment that that crosslink reattaches to that other fiber, then it's considered to be chronic. And by definition, at that moment, it becomes chronic. So you can see that the sooner we fix that acute trigger band, the better these people are going to do. The problem with chronic trigger bands is that when that crosslink reattaches or misattaches, it can affect that other fascial band in a very negative way. And it can pull on that other fascial band. And when it pulls on that other fascial band, it causes it to become distorted, and it becomes a trigger band, and it may tear, and its crosslink may reach out and grab onto something else. And when it grabs onto another fascial band, then it pulls it, and it distorts that band. And then that one tears, and its crosslink reaches out, and it grabs on to another band. And this goes on and on and on and spreads like a cancer almost. And when that happens, in this model, we call that fibromyalgia. And the treatment of all these is with trigger band technique. Let me just go back one thing right here. So again, with the acute trigger band, we want to treat this with trigger band technique. We're going to take our thumb, and we're going to force those separated fibers back together, realign those crosslinks. In the chronic trigger band, we need to break those crosslinks. We need to break those adhesions. Otherwise, that injury will stay forever chronic. So in this model, we have a chance of actually curing a chronic fibromyalgia because we break those adhesions and we force those trigger bands back together. Now, when you treat the acute trigger band with trigger band technique, it's going to be a somewhat painful procedure. Although some people really don't feel that. They think that it feels great. It feels good. It's the right thing to do. This can also be true with chronic pain. But you're going to be sore after a chronic pain treatment because you've got to break those adhesions. And if you fail to do that, the patient won't be sore, but they won't be helped. And so in chronic pain in particular, this is a very aggressive treatment. To break those fibers in chronic pain, you use a very vigorous trigger band technique. But in addition, there's something else called the comb technique. And I brought a comb here. I don't know if everybody can see this. But this is a comb that I use in my office. And it's a PET comb. It's a steel comb. And you can rake this along the involved area, particularly the upper back, which is famous for fibromyalgia. And that helps break those little superficial fascial adhesions. And then after this, these people really do quite a lot better. They're very thankful for this treatment. The comb itself can be uncomfortable, but a lot of people love the comb. It goes about 50-50. Some people say, I hate the comb. Some people say the comb is the best thing I've ever had in my whole life. So it's variable. So if you have somebody that doesn't like the comb, wait for the next patient. They'll love it. One other point here on the chronic pain, you can see in the picture here in the front of the parrot pulling on the pant cuff, you can see that that creates a wrinkle in the pant all the way up to the belt line where that can be felt. The same is true of all trigger bands, that they create a wrinkle that can be felt. It gives us proprioceptive information. In chronic pain, with all these fascial adhesions, then that distorts our brain's ability to interpret that. And so these people, when they come into you with chronic pain, they say, well, where do you hurt? They may not say, oh, I hurt along in here. They'll make a motion with their hand. They'll make the sweeping motion, just like an acute trigger band. But they'll say, I hurt all over. And the reason they hurt all over is because they can't interpret this pain. Their brain just can't do it. It's being pulled in so many directions from all these adhesions. Okay, on clinical examples of commonly seen trigger bands, I think probably most of you out there, if you haven't seen these, you will, because I see them every day in my office. I wanted to show you some of the most common ones. And the one on the left is called the star trigger band, and it starts halfway down the scapula. So if you take the scapula and you go halfway down, it'll be right there, and then it's halfway between the scapula and the spine. And right there is a point, and people will come in and they'll say, oh man, my back hurts, and they'll do this. And a lot of times patients will describe that as a knot. They'll say, I've got a knot in my upper back. This is what they're talking about. This is a star trigger band. The trigger band on the right is one where people will come in and they'll say, my back hurts. But if you look at this trigger band pathway, you'll see that it usually doesn't even involve the back, although it can. It usually comes from right here, sometimes down here, but usually right here. It comes up this way, all the way like this, and sometimes into the low back, but it comes up like this and here. And there's so many patients that say, I have low back pain. I'll come in like this, making this sweepy motion. That's not even in their back, but this is this trigger band. These are two of my favorites. The one on the left is the anterior shoulder pathway, which I talked about. It starts in the anterior forearm, right here, and it comes up this way, through the bicipital groove, up to the mastoid on the same side. The best way to treat that trigger band, as with all trigger bands, is to start at the starting point and bring it along and correct the twisted fibers along the entire pathway. Probably in my office, I do this trigger band more than any other trigger band. I do this maybe 20 times a day. It's that common. Also, just on the anterior pathway, this trigger band can cause a lot of confusion, as all trigger bands can, because it can hurt anywhere along that pathway. And so sometimes they'll have neck pain and they'll be doing this. This can still be that anterior shoulder pathway. And if you ask them to bring the arm back, they'll force it up like this. This is still that pathway, even though they have neck pain. And in acute pain, you may talk to them later and they'll say, yeah, now it hurts down here. That pain moves. It can move anywhere along that pathway. Anytime the pain moves, that by definition makes it a trigger band. Movement of pain in a linear direction. And when you treat that trigger band, you can move that pain. They may have pain right here, but you can move that up the arm. And you can move it back. But it's a change in location of the pain along a linear fashion. And when you see that, that's always a trigger band by definition. The trigger band on your right is a posterior shoulder pathway. And this one can cause confusion in upper back pain because people may come in and they'll say, my back hurts, and they'll make a motion like this. And when you ask them to bring the arm back, it doesn't really go back. That's the posterior shoulder trigger band pathway. The best way to treat that is along its entire pathway, which starts just right here and comes up along the back and then to the opposite mastoid. Now, if you're treating one of these trigger bands, and you take that twist, and as you move that twist along, you can leave that twist behind. And if you do that, that patient will have pain in a new location that they didn't have before. So if they come in and they say, man, it's hurting right in here, and you treat that, they say, yeah, that feels better. But they say, it's hurting right here now. It didn't hurt there before. What happened? That means you've moved that twist to a new location along the pathway, and you haven't completed your mission, which is to correct it along its entire pathway. This is an example of the anterior shoulder trigger band pathway. And this patient here, we're going to start. This is a starting point. And you can see that there's a lot of force involved in this technique. These are not gentle techniques, although they can be. They're not meant to be gentle. Patients really don't mind. Nobody ever refuses this treatment. I've worked 5 years in the emergency room. I can't remember ever anybody refusing this treatment. Because intuitively, when you have a patient with the trigger band and you start to do trigger band technique, intuitively those patients are going to say, yes, you're doing the right thing. Yes, this is uncomfortable, but I feel like you're doing the right thing. And they'll let you do the treatment. I haven't had one complaint in doing this technique in the emergency room. And you would think they complain about everything else, but they don't complain about this. And so we want to start here on the anterior proximal forearm. And if you can look there, there's quite a bit of force. To get it started on the anterior pathway, you must hold your thumb in this direction. I don't know if you can see that. You cannot keep the thumb this way. If you do that, you won't get the force necessary. Your thumb will tire and become sore. You won't make it all the way up the shoulder. You must keep the thumb this way. So to start, we have to find that trigger band, which will feel like an irregularity of the tissue, stick that thumb in there, and pull it all the way up that pathway. So there's where we start. Now you can see we're moving up the arm. We're moving up through the bicipital area. This is not a pain-free procedure, although it can be, but it probably shouldn't be. And all the way up to the mastoid. Side effects of trigger band technique. include pain, although a lot of patients, especially in acute pain, will tell you, this hurts so good. They'll say, I love this. A lot of patients love this technique. In chronic pain, a lot of times they'll tell you it hurts. Some people will tell you that this is the most excruciating pain they've had, even worse than having a baby. That's unusual. But just remember, if you're doing this technique, and the patient says, gee, that didn't hurt at all, you didn't do anything. We need to make an anatomical correction. You know, this technique is meant to be painful. We cannot change the anatomy. If we're going to do something, then we have to do it. We have to change the anatomy. Erythema of the skin occurs 100% of the time when this technique is properly done. You should see a red streak with trigger band technique 100% of the time. If you don't see a red streak, you didn't push hard enough. Bruising occurs uncommonly in acute pain. In chronic pain, for me, it occurs 5 to 10% of the time. For you that are going to give this technique a try, you might see initially 50% of the time. Generally, bruising occurs because you went off the fascial band pathway. When you go off the pathway, you damage other tissues and you get bruising. Patients don't mind bruising. They really don't. They've had pain for years. Everybody has done everything to them. They've been everywhere. They don't mind bruising. None of my patients object to it. And even in the emergency room, they don't object. Contraindications. My feeling on contraindications is that everybody needs to use their own best judgment. If you don't feel comfortable treating something, don't treat it. You don't have to use trigger band technique. Even if you say this is a trigger band, and you say, I don't want to use trigger band technique because I don't like trigger band technique, or I don't think this patient will tolerate that procedure, or I just don't feel like using it because it's too hard on my hands, or whatever your reason is. You don't have to. Nobody tells you that you have to use trigger band technique. If you don't have to treat it at all. There are other techniques that can affect trigger bands. Some of the myofascial release techniques and muscle energy and Jones techniques, all these things do affect trigger bands. They're not going to be, in my opinion, as specific and as dramatic as trigger band technique, because trigger band technique is specifically designed to correct trigger band. But they do work, and you can use those other techniques. And in some cases, you may want to do those instead of trigger band technique, because trigger band technique is a much more aggressive and physical technique than those other techniques that you know about. On some of these contraindications, my feeling on all of these is they're relative contraindications. For instance, bleeding disorders. I treat people with bleeding disorders. I've treated people that are hemophiliacs. And I treat a lot more things than I want to, but the patients are desperate. When they've had chronic pain their whole life and they want something done, people with bleeding disorders have all said the same thing to me. I tell them, you're going to bruise like hell. They say, I don't care. I've bruised my whole life, and one more bruise isn't going to make any difference to me. And the amazing thing that I found about bleeding disorders is that they'll tell me that even if you blow on them, they'll get a bruise. But with trigger band technique, their bruising was minimal. And that was because I stayed on the fascial band. If you stay on the fascial band pathway, you make the correction without bruising. And they were really quite surprised that they didn't bruise. They said, I've never been touched anything like that without bruising. Even if I bump my knee, the whole thing will bruise. On the other ones here, obviously any kind of infection or anything like that, you want to avoid any kind of skin contact with it. Treatment of the abdomen or pelvis during pregnancy, I treat this because there are people that are in pain that want to be treated. I just put it up there for you to use your own best judgment. If you don't feel comfortable doing it, you don't have to. Arteriosclerosis, I treat this all the time. That's, arteriosclerosis is everywhere. Phlebitis, I would recommend you don't do that. Vascular diseases, these treatments do work for a lot of different illnesses such as rheumatoid arthritis. Trigger bands are one of the 6 distortions in the fascial distortion model. And there are 5 others. I'm just bringing them to your attention here because everything is not a trigger band, although trigger bands are the number 1 most common thing, most common fascial distortion of the 6. And if you had if everything was one nail and you had one hammer, to me, trigger band technique would be that one hammer and that one nail. I had to show a shot of Maine, and this is a shot of Maine. This is Thunderhole, and if you watch those people right there, they're about to get a surprise. And there's their surprise. I wanted somebody just before I came up here wanted me to touch on something real quick, so they wanted me to talk a little bit about the future trigger band technique and some of the other things that can be treated. Trigger band technique, I think, has a future that will include a lot of orthopedic types of injuries, particularly those that may be intrasurgically. So if somebody has an injury such as a hand injury, trigger bands are going to form during that injury. And when they go in there and they repair the bones, in the future I envision that we're going to have techniques that will be intrasurgical to correct those trigger bands at the time of the surgery, so that there isn't a long type of drawn out rehabilitation. There really isn't any reason for somebody to go for weeks and weeks or months and months of rehabilitation. If we can correct that during the surgical procedure itself, they won't have trigger bands, and then they're going to have a very fast type of recovery. Also, these fascial bands are, I've talked all about musculoskeletal here, but they also involve other areas, such as through the abdomen, along the gallbladder. They hook around the ureter, and so trigger bands are responsible for causing some impingement of the ureter itself. So when a stone goes through, it can cause renal colic. And so in the emergency room, I've treated hundreds of cases of renal colic with trigger band technique. In addition, fascial bands are found in other parts of the body, including coronary arteries and the vertebral arteries and different vascular systems. So if you can envision an injury to a shoulder with the trigger band, you can also envision an injury to an artery with the trigger band. And in the future, it seems likely that we're going to have intrasurgical procedures on correcting distortions of trigger bands along coronary arteries that are causing an impingement of that artery. And if you think of that pulled muscles, the pain coming and going as that twist gets pulled in and out, then you can think of a coronary artery as the twist gets pulled into the musculature of the artery, impinging that artery. And in this model, we would call it angina. And then when it gets pulled out again, or we give a nitroglycerin, then the pain is gone. But it comes back because it hasn't been corrected. In the future, we may have intrasurgical procedures during coronary surgery where instead of going inside of the artery, we're actually going to affect the outside of it. So that's just a little glimpse of the future. But one of the things I wanted to do is I wanted to take some questions, but I also wanted to demonstrate the technique. Do we have anybody in the audience that would like to come up who has a pulling, burning type of pain along a linear fashion? So, do we? Let's take them both. They can both come up. Now come on up this way. Okay, tell me, what is your problem?
Right here, pulling, burning, goes down the back of my shoulder.
Okay, so where's your pain at? Is it here? I don't know if we can see it. Okay, show us again.
And I can't really reach it, but
Okay.
in that region
Okay,
there.
and it comes up
and it
here?
comes down here.
Okay. So I think what she's telling us here is that she has a pain that comes down here, and she also has a pain here. This is a star trigger band. It's going to actually pull all the way up to here. She's also got a posterior pathway. Let's see if the shoulder is affected. So just bring your arms up like this. And that looks okay. Put your elbows back this way. Okay, that looks fine. Go ahead and drop. Now with your left arm, which is your good arm, I want you to go ahead and bring it up like this. This is outstanding motion. And those of you that come to the workshop, you'll see there's no flaring here. So this is outstanding motion, nice and smooth. Fingers are straight up and a good speed. Let's see the other side. And you can see this motion is awkward. There's no flaring. The fingers are right here. This motion is okay, but that tells us that this shoulder is beginning to be involved. What I think we'll do is, if you don't mind, I'm just going to put a mark on your back here. And just drop your arm, if you would. So we can see it's right there. Okay. So why don't you sit right here. And with trigger band technique, you cannot go through the clothes. We're making an anatomical change. So we're going to find this right here. We're going to push into the starting point of the trigger band, and she'll tell you, does that hurt? She says yes. And what I do is I lean into it. So I try to use my weight rather than my strength, because you get tired at the end of the day. Okay, so, I'm sorry? Okay. Like this, is that better? Other way? Okay. Okay, let's try it again. Okay, again with the star trigger band, we're going to take the scapula here, and it's going to be halfway down the scapula, halfway between the scapula and the spine. It starts right here. We're going to push all the way up to that mastoid, okay? This is a little bit harder than it looks. On the posterior shoulder trigger band pathway, we're going to find an irregularity that starts right here. This is going to come, I did this with one hand, but for you, your thumbs probably aren't as strong. And we're going to bring this all the way up. And I go at a much faster speed than I expect other people to go at. I'm sorry? You cannot use cream, lotions, or gels because it'll decrease the friction. And again, you're making an anatomical change underneath the skin. And you need that drag on the skin to make the correction. There's not a problem if you take your thumb off. No, you can do that. I'm sorry? The pathway can go either way. As a gym, he wanted to know, do you always go towards the center of the body? So what he's really asking is, does this pathway always go up? And the answer is no. It goes up about 90% of the time in this particular pathway and down about 10% of the time. And if you think about the Ziploc bag, you can see, if you use that analogy, sometimes it's better to zip that Ziploc one way, and sometimes it's better to zip it the other way. So we're going to go across the back. And you don't always know. As a general rule, the patient can help you, though. They'll use their hand, and they'll make the first motion they make will be a sweep up. But if you have to guess, just like what this gentleman came to the conclusion, always guess up, okay, in this pathway. Now, on ankle sprains, trigger band ankle sprains, it's just the opposite. It's 90% go down. No, that's not significant. He wanted to know about sequencing. Does it make any difference whether we go treat the star first or the posterior shoulder trigger band pathway? Okay. All right, go ahead and stand up here. These are all due to injuries. These are unresolved injuries. Okay, go ahead and bring your arm up again. Yeah. Does that look different?
Yeah, wow.
See how nice and smooth that was? So go ahead and drop. So we're right there, so we gained a couple inches. Okay, we got one more. I'm going to let you go, okay? And what is your problem?
I have pain here, up into the shoulder, into the neck.
Okay, show me where again?
Down here,
Okay.
up into the shoulder.
Okay, so again, she's really talking about the anterior shoulder trigger band pathway and then something else too. So let's just take a look at her motion. Okay there? Go ahead and bring this left arm back.
Right arm.
That's your right arm. Okay, I'm going to make a mark here. Go ahead and drop. Now see the other side? And so I usually mark both. They're just about the same. Let's just look at that shoulder one more time. On the right side, bring it back. You see this hole here? That's called flaring. That's not good. And see the direction of the hand? That's not good. Those fingers should be straight up like our last person here. So that tells us that this is an injury of the shoulder. Okay, so in this case, we're going to go as fast as we can here. Come sit right here, facing this way. Actually, let's have you face the other way because we're going to do the anterior pathway. And does anybody else have questions? Because we're running out of time here. Well, again, in this model, if you were to look at Travell's trigger points, that's a different way of looking at kind of the same thing. But this is an anatomical model looking at the anatomy of it. There is no referred pain. It's a mechanical type of pain. And in my opinion, obviously, this is going to be a much more successful type of treatment because you're anatomically correcting it. If you go in there and you just treat that trigger point, what you're really doing is you're just moving that trigger band just a little bit of ways. You haven't corrected along its entire pathway. And so you have to treat over and over and over again. Whereas when you do this, you've made the correction. It's gone. It doesn't exist anymore.
This problem has been treated with Volunteer and with massage.
She just said that she's had multiple other types of treatments. So. And again, we start, I don't know if you can see here. Ooh. It said that, I'm sorry? This way? On the end, on the end.
Okay.
Okay, yeah, that's better. So we're going to start here, and you can see the direction of my thumb is straight down, down, and then up. And I like to take my other hand and I pull on it a little bit, giving it a little bit of traction.
I can feel that.
Yeah. How do I know? Because I've done 1,000 of these or 1,000,000 of them. But no, really. The way that you know is that there's going to be an irregularity in the tissue, and the patient will tell you, that's it. As I go up here, if I start to wander off, she's going to say, you're not on it. You're not on it. It doesn't hurt anymore. You're off of it. When you hear those words, that means you're off the fascial band. And the patients will be very consistent. They don't know one thing about this technique, but they're going to know when you're on it and when you're off it. So, I hear a buzzer here, so I got to hurry. In chronic pain, as a general rule for a frozen shoulder, in other words, somebody that can't get their arm up like this, or they can't do this, it's about an average of 5 treatments. With the first treatment is the most aggressive, and then I bring them back in about 3 days, treat again, bring them back 2 days, treat again, bring them back 2 days after that, and then 2 days after that. But I'd also use the comb, too, on chronic pain. There's no maintenance required, but they do get other injuries. There is, I have some of these that you saw up here that are in a paper that I had published in the AAO journal. And there's 2 of them in summer and winter of 1994. So up we go, up to the mastoid. And her problem is going to be actually chronic, so we'll see how well we did. I'm sorry? I'm still on the trigger band pathway, and I'm all the way up to the neck. So you'll see people that come in with neck pain right here. This can still be this anterior shoulder pathway. I put traction on the arm. You don't have to. It just makes it easier to, when you stretch that band out, it's easier to make the correction on it. As you stretch, it's easier to force the fibers together. You don't have to. I like to do that. Okay, does everything stand out? And let's try it again. Bring it back. And does that look different? Remember this here? Can you go any higher? Okay, so you can see we're right here. See now the hand is straight up, so go ahead and bring it down. And here's where we were just a minute ago. So here's something that I always do in my office, is I like to quantitate things. So I bring a tape measure, and we got about 3 inches there. And sometimes, in especially acute pain, this can be very dramatic. You can see 6, 8, 12 inches. You'll have somebody that comes in, oh man, I fell off the roof. Thank you. And they can't bring this arm up like this, and when you get done with it, it'll come all the way up. Any other questions? Yes? I'm sorry, I can't hear the question. Accumulative trauma, again, is, if you think about accumulative trauma, what's happening is that fascial fiber is constantly being pulled apart all the time. And so this works very well for that, such as carpal tunnel and different things. Is that it? Yeah. Thank you.